we'll wait a couple of minutes after the hour just to give a chance to more people to join. Welcome everybody to this month webinar of the Cerebrovascular section of the World Federation. On behalf of myself and on my co-moderator, Professor Fujimura, we'd like to welcome you to a very informative morning or evening, depending on where you are, on cavernous malformations. We have two speakers that will cover the general and clinical aspects of this topic, and as well as the surgical aspects. And then Professor Fujimura will present, and we will discuss some cases. The first speaker is Professor Kelly Fleming, a neurologist and professor of neurology here at the Mayo Clinic in Rochester. She is and has been one of the leading figures in the understanding of the natural history and clinical evolution of cavernous malformations. She could not be here with us today for she had another engagement, but she was kind enough to record the video that I will start, and we will hear about the overall management of cavernous malformations, particularly with the neurology point of view.
And these are at the level of the capillary. I have a few disclosures. So these are the typical questions I might get asked as a neurologist. In the first panel, you see a patient with multiple SWI lesions, and they wonder, are these cavernous malformations or Could they be something else like amyloid angiopathy? The second patient wants to know what's the risk of observation, what's the natural history versus what's the risk of surgical intervention in this particular situation. And finally, the third patient wants to know what medications are okay to take and what medications might worsen the natural history. And so these are the typical questions I might get asked. Let's just start with what is a cavernous malformation. A cavernous malformation is composed of multiple endothelial-lined caverns, and these are at the level of the capillaries. On a 7 Tesla MRI, you can almost envision seeing those individual caverns where some are bright white, suggesting subacute blood or thrombosis within a cavern, and others are isodense. At the microscopic level, it's the tight junctions that are dysfunctional and the leakiness of the endothelium. And that leakiness can sometimes lead to symptoms. It is not uncommon that some patients are discovered to have a cavernous malformation incidentally, meaning the symptoms are not related to the cavernous malformation. Other patients may present with focal neurologic deficit attributable to the location of the lesion, seizures, or headache. Deficit, seizure, or headache is radiographically associated with hemorrhage. We call it a symptomatic hemorrhage. However, there are patients that have focal neurologic deficits that localize to the location of the cavernous malformation, but there's no obvious radiographic evidence of hemorrhage, and we call them FND, focal neurologic deficit, NOS, not otherwise specified, or non-hemorrhagic. And sometimes these may be non-hemorrhagic because the imaging was delayed from the time of the symptoms, or because some people will have seizures without radiographic evidence of hemorrhage. But you'll see those words in the nomenclature. Cavernous malformations come in two different types. The sporadic form, typically characterized by a single lesion. The cavernous malformation there is noted by the yellow arrow, often with an associated developmental venous anomaly noted by the red arrow. Sometimes the developmental venous anomaly may not be visible on standard sequences like the gadolinium or the SWI, in which case sometimes 7 Tesla MRI can show it. To the right on the top is a very large developmental venous anomaly. When you see large developmental venous anomalies, sometimes they can be associated with multiple cavernous malformations surrounding that DVA. The lower panel shows the typical familial form. So typically there are more than one lesion and often without a developmental venous anomaly. Sometimes it may be 2 or 3 lesions, and as you see in the patient below, sometimes there are more than 50 or even more than 100 lesions. There are 3 known genes, CCM1, 2, and 3. All are autosomal dominant. The familial form of cavernous malformation also, in addition to the cavernous malformations of the spine and the brain, may have retinal angiomas. They may have these skin lesions, which are characteristic of a dark purple or black raised areas on the skin. Sometimes they'll have angiomas of the kidneys and the liver and of the vertebral bodies. And CCM3 in particular can also be associated with benign brain tumors. In the familial form, approximately 60% of patients will have a lifetime risk of at least a single seizure and a 40 to 60% chance of at least one bleed. So I'm going to talk about, one, how do we secure the diagnosis of a cavernous malformation and make sure it's not something else? Number 2, talk quite a bit about the natural history and some new data. The treatment options in terms of treating the lesion, I'm going to leave surgical recommendations to Dr. Schur, but I'm going to talk about some of the emerging opportunities for treatment, and then finally talk about a few comorbid conditions that often come up in discussion with these patients. CT scans are very insensitive for picking up cavernous malformations and especially for picking up any intracavernous hemorrhage. You might see something such as this where there's a hyperdensity on a CT, but many times you don't see much at all. And on conventional angiograms, they are typically negative because, again, these lesions are at the level of the capillary. So by and large, the diagnosis is secured by looking for characteristic picture on an MRI scan. The T2 scan often has this characteristic looking lesion that is often likened to popcorn or to a mulberry, where there's a reticulated center with a dark area around it, the hemosiderin. And these are always dark on SWI or GRE sequences. The T1 generally shows us if there's any subacute hemorrhage, and T1 with contrast is really to help us rule out other causes for such a lesion. The cavernous malformations typically are either non-enhancing or mildly diffusely enhancing. The guidelines suggest an MRI is recommended for the diagnosis, but that catheter angiography is typically not recommended. And I usually do the first scan with gadolinium or with contrast to help me make the diagnosis, but once I've secured the diagnosis, follow-up scans do not require gadolinium. We can further break down the cavernous malformations into the Zebromski types. So type 1 is acute hemorrhage. Type 2 is that very characteristic looking popcorn appearance. Type 3 is isodense to hypointense on T2. And type 4 are those that you just see on a hemosiderin sensitive sequence, so like an SWI or a GRE sequence. So type 1 and type 4 lesions have a broader differential diagnosis, whereas that type 2 is very characteristic looking. And so commonly I'm faced with thinking through, is this a cavernous malformation or not when they've acutely hemorrhaged, or if you see the multiple SWI lesions, are we sure it's not something else? So a couple helpful tips. If there's a developmental venous anomaly, it really helps because then you can secure the diagnosis. Sometimes a 7 Tesla MRI will show that DVA better than a 1 or 3 Tesla MRI. The other thing that we've noticed looking at radiographic natural history is the edema that you see with cavernous malformations will uniformly go away after about 90 days unless they rebleed. So if you see persistent edema like you do in the patient in the center panel with the myxoma or with the renal cell carcinoma, those persistent edema over 3 months would be highly unusual for cavernous malformations. And sometimes it's just really hard to tell in the acute phases of the hemorrhage what is this lesion, but repeating the MRI in 6 to 12 weeks helps the lesion evolve a little bit more to that characteristic appearance. In the patients with multiple SWI abnormalities, is it cerebral cavernous malformations? Is it amyloid angiopathy? What is it? It's always helpful to look for at least one standard looking or characteristic looking lesion on the T2. If that's not present, you can consider genetic testing. 95% of people with the true familial cavernous malformation syndrome will have an abnormal gene. Sometimes we've done spinal fluid to try to figure out is it amyloid or not. There should be subcortical and cortical lesions in familial CCM versus amyloid tends to be more cortical. And then also when you look at the pattern of the SWI, if it looks unusual, consider a CAT scan because calcium can also look like microbleeds and you may pick up something else. And neurocysticercosis is one that has sometimes been mistaken for cavernous malformation. Now we're going to switch to natural history. So what is natural history? It's the usual course or development of a disease in the absence of treatment. And why is it important? Is because we want to look at what is the bleed risk or recurrent bleed risk compared to what is the risk of a surgical or medical intervention. It used to be we looked at retrospective natural history, assuming that the lesion was present since birth. However, we now know that that is not true. And so now we're really focused on this prospective natural history from the time of diagnosis to the time of some future event like symptomatic hemorrhage. If we were to group all the patients together that have cavernous malformation, the incidental group, those with symptoms, we get about a risk of 2 to 3% per year. However, we can further stratify this risk with some other features. So this data is from the Horn meta-analysis using 5 cohorts and looking specifically at brainstem location versus non-brainstem location and whether they presented with hemorrhage or no hemorrhage. And what you see here, both in the Kaplan-Meier curve and the associated graph, is that the highest risk of another hemorrhage is those with the brainstem location that initially presented with hemorrhage. Those patients had a 30.8% risk over 5 years of another hemorrhage. The next highest risk was those with a non-brainstem location that presented with a hemorrhage, and that was about 18.4% over 5 years. And then those that did not present with hemorrhage had a much lower risk. You can also see that the lines tend to plateau around 2.5 years, suggesting the highest risk is in the first few years after diagnosis. Now, the caveat here being that median follow-up time in this study was about 3.5 years. Uniformly, of the 20 plus, probably 30 natural history studies that exist now, uniformly, there are consistent risk factors: age less than 45, symptomatic hemorrhage at presentation, and brainstem location. Most studies suggest that those are true. There are smaller studies and limited data that show a number of other features, both clinical and radiographic, that might change the risk of hemorrhage. And then there is some conflicting data. For example, developmental venous anomalies. Some studies say that it does not make a difference with the bleed risk. Some say it does. Some stratify the type of CCM DVA complex, and maybe that makes a difference. But like I said, uniformly, there's been some very consistent data on symptomatic hemorrhage, brainstem location, and age. Despite there being so many natural history studies, we wanted to study this ourselves in a prospective way involving patient input and doing it in a contemporary fashion, and specifically looking at some specific MRI characteristics at baseline and MRI characteristics in follow-up. And specifically, one of our goals was to look at the characteristics on a follow-up MRI done about 3 months after presentation. Why 3 months? Well, blood tends to have a specific evolution over time on T1. Oftentimes we see the bright T1 or subacute blood when we see a patient that has had a new focal neurologic deficit or seizure. By 1 month, this should turn isodense or even dark with time on the T1 images. So we specifically wanted to look at a follow-up image that was at least 3 months after the initial to make sure that we were seeing this evolution of the hemorrhage. So what we were particularly interested is in the evolution on the T1, and we saw several patterns emerge, and we grouped these together as a persistent high T1 signal for asymptomatic hemorrhage when we looked at outcomes. So for example, in the top row, this patient presented with acute confusion in November of 2014, and you see these hemorrhagic caverns in the left temporal lobe. Some of the caverns become isodense by January of 2015, but there is one cavern that stays persistently bright, and so that we called persistent high T1 signal. In the lower panel, we see a patient that presented with hemorrhage noted by the green arrow that persists in a bright T1 way on the April 2010 film, but also has an asymptomatic new hemorrhage just inferior to it. So again, we grouped this finding together when we were looking at outcomes. This is the Kaplan-Meier curve from our data. What you noticed is patients with symptomatic hemorrhage at diagnosis, the blue line, have a much higher risk of recurrent hemorrhage than those with no symptomatic hemorrhage at diagnosis, the red line. By 5 years, the cumulative risk of proportion of patients with a recurrent hemorrhage is 41.2% in the symptomatic hemorrhage at diagnosis group versus 6.1% in the patients presenting without a symptomatic hemorrhage at diagnosis, but remember, some of them do have symptoms. In addition to looking at the first prospective symptomatic hemorrhage, we looked at first prospective severe symptomatic hemorrhage. Recall that it's a modified ranking of 3 or higher at the time of the hemorrhage. And those numbers were 12.8% in the symptomatic hemorrhage at diagnosis group versus 2.5% in those without hemorrhage at diagnosis. Patients about. When we looked at univariate analysis, the typical things came with a positive p-value, age less than 45, symptomatic hemorrhage, brainstem location. We also saw that asymptomatic hemorrhage, increased T1 signal that was persistent, and CCM size greater than a centimeter seemed to be significant in univariate analysis. But when we did the final multivariate analysis, symptomatic hemorrhage at presentation and persistent T1 or new T1 signal were the only things that came out in that analysis. So in our data, if they had a symptomatic hemorrhage at presentation, yes, and then an MRI done at least 3 months later had persistent high T1 signal or new high 1T signal, yes, that was a 50% chance over 5 years of a bleed, versus if they did not have that follow-up characteristic, it was a 19.3% risk. If a symptomatic hemorrhage at presentation, no, to the right side of this algorithm, but they did have the persistent or new high T1 signal, then it was a 4.4% over 5-year risk versus a 1.2% risk. And so again, this is another way to stratify your patients once you do that follow-up MRI. And here's a great example of this finding. So this patient in January of 2013 had very severe obsessive compulsive disorder to the point of being hospitalized, and she had not had that before. This lesion that involves the caudate head we think was symptomatic, and you can see the hemorrhage. You can see in January of 2014 at the green arrow that there was some persistent high T1 signal, even though the major part of the hemorrhage has gone to an isodense appearance. In February 2015, without any new symptoms, she had 2 areas of what I would consider asymptomatic hemorrhage or intracavernous thrombosis at the blue arrows. And then in late 2018 had a seizure, and the MRI was read as stable, but indeed there is a new cavern that is bright on T1, suggestive of a symptomatic hemorrhage. We are at Mayo also involved in the CASH biomarker study, along with the University of Chicago and UCSF and Barrow Neurologic Institute. Dr. Gerard at the University of Chicago is heading this study, looking at certain plasma proteins and microRNA. Can we predict who is going to hemorrhage in the next year? So wouldn't it be great if the MRI characteristics and the biomarker could help us predict which patients would benefit most from intervention? So moving to treatment options, I'm not going to spend a lot of time talking about lesional treatment because Dr. Schur, who follows me, is going to talk about surgery, which by and far is what we're talking about with treating the lesion, is are we going to consider surgery or observation? There may be a role for stereotactic radiosurgery in sporadic form cavernous malformations that have bled in a very difficult location to surgically extract. Laser interstitial thermal therapy is an evolving technique often considered for some seizure disorders and superficial lesions. Again, evolving data on that, mostly from single center cohort studies. Focused ultrasound, not the thermal destructive type of focused ultrasound, but the focused ultrasound that has mechanical disruption is being evaluated as a possible treatment at University of Virginia. And I want to touch on some of the medication and lifestyle things that we talk about with patients as a neurologist. So I often start by talking about lifestyle changes that might be useful for patients so that they can have some control over this disease. The items along the bottom in purple have very limited data, but it makes sense to limit alcohol, stop smoking, identify and treat sleep apnea, and treat high blood pressure. Along the top, we talk about vitamin D. There's indirect evidence that lower vitamin D is associated with bleeding compared to higher levels. No clinical trial evidence as to whether vitamin D supplementation is helpful, but has low risk and might be considered. There is data on the gut microbiome and a diet free with processed foods that might be something that you can talk to patients about, and there's more information on the Alliance to Cure website. And then we talk about which medications might be safe and even beneficial, and which medications might have a deleterious effect on the cavernous malformation, and I will mention those shortly. What's really exciting is that we're learning more and more about what the CCM complex does and how it regulates the endothelial leakiness and the tight junctions. In particular, I want to point out something called RHO-A and ROCK. That's where we think that atorvastatin acts. And RHO-A and ROCK modulate the endothelial leakiness. By knowing a lot of these different targets, it has allowed us to develop potential targets for various therapeutics. And the goal is that could we reduce the risk of bleeding? Could we reduce the risk of new lesion formation through medications rather than surgical intervention? So 3 important clinical trials to pay attention to and look for upcoming: the CASH-EPOCH trial, atorvastatin 80 milligrams daily versus placebo in patients with recent clinical symptomatic hemorrhages. Results anticipated late this year or early 2025. The TREAT-CCM trial was an open-label phase 2 pilot trial in familial cavernous malformation patients. 83 patients were randomized 2-to-1 to either propranolol, low dose and escalated, versus placebo. And there are a lot of ongoing data going to come out of this trial. In the initial pilot, there was a slight reduction risk of hemorrhage with 2 events in each group, but a slightly lower hemorrhage risk in that therapeutic group. Finally, the Sycamore trial anticipated results sometime later this year. Tempol is an antioxidant. We'll look forward to hearing this phase 2 trial result. So now I'd like to spend a little bit of time talking about some of the comorbid conditions patients ask us about. Specifically, patients will commonly ask us about using aspirin or NSAIDs or blood thinners. We get asked about pregnancy not infrequently. We get asked about what medications could be deleterious. And we often get asked about headaches. And I don't have time to review all of these things with you. And so I'm going to briefly talk a little bit about the antithrombotic data and the female hormone data that might impact your patients. In a study that we participated in along with 4 other centers, we were interested in what is the risk of antithrombotics. So you would think that blood thinners would increase the risk of bleeding, but in fact, what we saw is those patients using antithrombotics, so the 253 of 1,342 patients, had a lower risk of bleeding from the cavernous malformation than those not on antithrombotics. So a 0.5% per year risk of bleeding versus a 2.4% per year risk of bleeding. And that was statistically significant even after adjusting for brainstem location, age, and presentation with hemorrhage. Now, the majority of patients in this study were aspirin. There were very few on things like Plavix and Brilinta, and very few on DOACs. So largely this was a study looking at aspirin. So again, paradoxically, blood thinners reduce the risk, and I'm going to come back to that concept shortly. In this study, we were interested in the effects of female hormones, specifically progesterone and estrogen, on the risk of bleeding. We combined data from Mayo Clinic with that in the Essen, Germany group of females that we had longitudinal data on, and we looked at those that had taken female hormones and those that had not taken female hormones, and looked at what was the risk of cavernous malformation hemorrhage. And we found a higher risk of hemorrhage, 7.4% per year, in those who had taken some type of female hormone versus 5.1% in those not taking female hormones. When you looked at patients taking female hormones versus never hormones, the risk of cavernous malformation hemorrhage was 1.6 times higher in the female hormone group. When you looked specifically at oral contraceptives versus never hormones, the risk of cavernous malformation hemorrhage was 2 times higher. And when you combined oral contraceptives and tobacco use, it was 4.9 times higher. When we looked at all menopausal hormones, no matter what the formulation or the delivery system, there wasn't a significant difference. But when we looked at oral estrogen in particular, that seemed to be more significant. So what is this paradox where antithrombotics reduce the risk, but estrogens and potentially progesterones increase the risk? Well, the concept is similar to that of cerebral venous thrombosis, where when you have normal blood flow going from the arteries to the capillaries to the veins, the blood is not clotting. But if you put a cavernous malformation there and the blood is not moving as quickly as it would, and maybe you add something like estrogen, which increases clotting risk, then maybe one or two of those caverns clots and the blood can't escape to the venous side, so it escapes to the brain. So that theory would make sense why aspirin or antithrombotics might reduce the risk of cavernous malformation hemorrhage, whereas estrogens in particular might increase the risk. So coming back to the female hormone question, so female hormones might increase the risk of cavernous malformation hemorrhage because of that estrogen increasing the clotting risk, and estrogen does so in a dose-dependent manner, which may be why we see oral contraceptives having a higher risk than menopausal estrogens. And often when estrogen is combined with other factors, like if a patient had factor V or if they were on tobacco, that may further increase the risk. Progesterone is an interesting concept as well, because there is basic science data suggesting that the CCM complex is negatively affected by progesterone, and that may also produce bleeding and or leakage from cavernous malformations. I consider the data on female hormones as very exploratory. There's literally 250 different formulations of female hormones, and they come in different types: oral, injectables, intrauterine devices, transdermal, transvaginal. And so we need to further hone in on which patients are at highest risk and which specific formulations might be the highest risk. Until then, I urge caution depending on the patient's individual situation and need for the hormones. We look at, have they bled recently? Have they had recent growth? How many lesions do they have? And try to take into consideration all those factors until we learn more. And very quickly, I'm looking forward to the updated Alliance to Cure guidelines, which will come out later this year or early next year. The familial cavernous malformation article was updated in the past year. I'm looking forward to the outcomes of the CASH EPOC trial, the Sycamore trial, and the ongoing Treat CCM and CARE trials. And there continues to be this evolution of basic science and more potential targets for therapeutics, and it's a very exciting time. And I'd quickly like to thank my Mayo collaborators, especially Dr. Lanzino, for all of his expertise and help both clinically and on research, and to my external collaborators, including Dr. Schur, Philip Damon, and Alejandro Santos. Thank you for your time.
Thank you, Dr. Fleming, for, as usual, a very extensive and comprehensive overview. I like just to reiterate and stress a few basic concepts that have been discussed in the presentation. The difference between the sporadic and the familial form, and the fact that in the familial form, we don't see associated developmental venous anomalies because, of course, the mechanism is related to a genetic predisposition rather than probably alter the venous outflow like in the sporadic form. The concept that is common to most vascular conditions, that if a patient has presented with the symptomatic event, particularly hemorrhage, the risk of rehemorrhage over time is fairly high. And as we have heard in our prospective registry, the cumulative risk at 5 years is over 40%. Important to consider, though, that despite this fairly high risk of further bleeding, the incidence of bleeding leading to dependence, so disabling bleeding, is it's much lower, and it's about 12-13%. This is a very important concept to consider, especially when we decide which patients we should submit to surgery, especially in the deep-seated lesions. As we know, many patients, they often recover to a very good level without treatment after a first symptomatic bleed. And it's often the transition from a second to a third bleed where the disabling event can happen. And the last very important and intriguing thing I like to stress is this evolving concept that antithrombotic medications like aspirin in particular, they might actually decrease the risk of bleeding in a patient with cavernous malformations. Of course, this is not something that we recommend. There are ongoing efforts to start prospective trials, but I think especially for the young colleagues, it's important to consider like something that might be at first counterintuitive, might turn to be the one of the potentially an important pharmacological intervention. And lastly, I would like to say that after operating and seeing several hundred patients with cavernous malformations, I came to the conclusion that anybody who says that they can understand cavernous malformations, they are lying, because there is a lot that we still don't know. And especially when you operate, one cavernous malformation often looks quite different than several others that you might have encountered. Professor Fushimura?
Yes. Okay, so can I move on to the next talk, next
Yes.
speaker? Okay, so it's a pleasure to invite Professor Ulrich Thür from University Hospital Essen from Germany. So today his topic is about surgical indications and techniques of cavernous malformation. So would you start your lecture?
Yes, I hope you can hear me.
Yes, perfectly.
And now I hope that you can can you see my lecture? I mean, can you see my presentation already?
Not yet, actually. You mean the slides? Not yet.
That's my slides. I have to try to again. Okay, what to do? Yes. I try to open my jump and then okay.
Imad, can you assist?
Yes, sir. Sir, when you click on the green button at the bottom, share.
I try to make it possible. Freigeben. Usually it works.
Yes, it's working.
Okay.
Yeah.
Okay.
It's now working.
I can see the slides.
Yes, we can
Please
see.
make it
So sorry.
slideshow, please. Okay, good.
So I'm sorry. I don't know what happened. So, dear colleagues, in particular, dear Giuseppe and dear Dr. Fleming, I was a little late to hear your entire lecture, but as I expected, it really shows that we all are sharing a hobby for many, many years, which is called cavernomas. And I'm extremely grateful that I can share some of my experiences on that topic with you. So I'm coming from Essen, which is a city in Germany, in the center of Europe. You see here a map of Germany, and in the middle of Germany, there is a region called Ruhrgebiet, which is heavily populated. And in the center of the Ruhrgebiet, there is Essen. And if we draw a circle of approximately 20 kilometers around it, we have 10 million inhabitants. So that is why we have quite a large catchment area and one of the largest departments within our country. So my today's topic is cavernoma. I included a little bit imaging because I think it's very important to talk a bit on that. Surgical indications and techniques. I definitely have no conflict of interest. As you can see here, it was my early on, I started research, also basic research on cavernous malformations. And maybe up to date, I published about more than 70 Medline papers on cavernous malformations. And when I took over the chairmanship in Essen in 2008, I built up a international national, in the beginning, national referral center for that disease, which led to the fact that we were treating quite a very high number of patients. And as a matter of fact, nowadays, we would look over more than 2,000 outpatient clinic, and we have a quite well-documented database, which is mainly done by my collaborators, in particular, Philip Dammann. There is a cooperation, Dr. Fleming also quoted that, with the Mayo Clinic, but also with the Scottish Cavernoma Register and the BNI and also others. So when we look at our own data, these are data from 2020. I just wanted to make a point that approximately 20% of the patients that we are talking about have their problem or have the cavernoma localized in brainstem, according to our data. And when we look into imaging, it's interesting to note, when I took over the chair in 2008, I found Erwin Hahn Institute here in Essen, that was one of the first to perform 7 Tesla imaging in humans. And we started early on to look at them in detail. And you can see here, for example, a close-up image of a normal human being that nicely shows how exactly particular venous images can be made by, for example, SWI imaging. And so we use this technology, the 7 Tesla technology, to clear some things that I think are important. Also, Giuseppe mentioned some of them already. All of you know that there are particular single lesions that are associated with developmental venous anomalies, a typical Caput medusa-like venous malformation that you can see on the right side here. But if we talk about sporadic cases, that means patients with just one cavernoma, I can tell you that if you look at 7 Tesla in SWI, you will also find something like you see on the left side here. This is what we call a typical venous atypia. So in sporadic cavernomas, you would find them in 70%, and in sporadic cavernomas, you would find a DVA in 30%. That is important to know. Now, if we look at patients that are diagnosed with multiple cavernomas and we look at their genetics, using the 7 Tesla data, we also find out something which is quite noteworthy. Look at these images. You saw the one already before. You see a DVA here, and you see several cavernomas in the neighborhood. And now look at this image. You see a lot of cavernomas in this patient, but you wouldn't see a DVA in this case, in this patient. Now, if we go into detail and we would check the genetic state, we would find in the above patient one of the mutations in one of the known genes, CCM1, 2, or 3. In contrast, we wouldn't find them in the lower case. And this is true in 100% of each patient, which tells us that if we look at the image like that, we can be absolutely sure that here there is a there is a genetic alteration, except when the patient has been irradiated in infancy due to malignancy, whole brain radiation. And if we see multiple cavernomas in the neighborhood of a DVA, these patients wouldn't have a genetic disorder. So only by imaging we can distinguish these patients. Next, I would like to talk about indications, when to treat a cavernoma. And let me start with the incidental cavernoma. So what do we know? I would like to show you one of the most important publications that we did. And this is on health-related quality of life in untreated cavernoma patients. These patients suffer a decreased quality of life compared to normal population. This is very important to know. And Kelly Fleming has already shown that there is a quite very low risk of hemorrhage, which is said to be 5 to 6% in patients that wouldn't have a hemorrhage before and would have a incidental cavernoma. These are the data from our own databases that shows a cumulative 5-year risk of all patients of only 7%. If we look at the natural cause, even in a 10-year study, the 10-year follow-up, we can see what Dr. Fleming has already shown. Those patients who had a hemorrhage before, have had a hemorrhage before, have a higher risk than those who wouldn't have such a hemorrhage. And also quite interesting, I will come back to that in a minute, is that patients with a cavernoma in the spinal cord would have quite definitely very much higher risk of rehemorrhage. So what should be the management of an incidental cavernoma in our view? It's very easy. we shouldn't touch it. And I go even a step beyond. We wouldn't even follow them. So we wouldn't follow them by a 1 year, 2 year, or 3 year follow-up. In our hands, we would not recommend a regular follow-up unless there's a clinical event. Then we would advise a MRI follow-up. So in conclusion, for these asymptomatic cavernomas, remember they have a decreased quality of life, and it's you that should consult the patients to make clear that maybe they shouldn't be so anxious, and you could help to increase their quality of life. And we at least wouldn't advise a follow-up unless there is a clinical problem. Dr. Fleming has shown it: hemorrhage, higher risk, and deep localization, particularly in brainstem, very high risk, which can be, there are publications that say 30 to even 60% per year. Dr. Fleming also spoke about other risk factors such as obesity, developmental venous anomalies, on the other hand, wouldn't increase the risk of hemorrhage. Also important to know. And here you see our common publication that also was quoted already by Dr. Fleming, the topic of female hormone therapy. There's also another interesting question. What's about the familiar and the sporadic cases if you compare them by the risk of hemorrhage? And this is very important for the families, members of families of genetic cavernoma disease. They wouldn't have definitely much more high increased risk of hemorrhage unless that they would even harbor more than 10 or 20 cavernomas. The same is true for children. Children wouldn't have a higher risk of hemorrhage when compared to adults. So if we speak about what is a very good indication for treatment, I can tell you a very good indication is epilepsy, and particularly if the cavernoma is localized in the temporal lobe and even more in the temporal mesial lobe. So what to do when a treatment is indicated? There are particularly a lot of papers on radiosurgery and surgery. My comment for possible radiosurgery is there are pros and there are cons. I always advise not to do radiosurgery. Reason is that cavernomas can be caused by radiotherapy, number one. And also, I unfortunately had to operate on dozens of cavernomas that had been irradiated, particularly by gamma knife, and had partially severe rehemorrhages. Dr. Fleming also quoted the CARE trial that has been enrolled in England or in Great Britain, that has been published in very recently. Those of you who are interested, look at it. But I must say that reading the first report on that, I'm very preoccupied, because not only I am very preoccupied, also other neurosurgeons, because we really want to avoid a Ruber effect, because the CARE trial so far only includes a very atypical panel of patients treated, for example, mainly by radiosurgery. And for that reason, also Giuseppe and I, we share another publication. We wrote a letter to comment on that. Maybe those of you who are interested, have a look on that. That has been published maybe 4 weeks ago. epilepsy. This slide should have been shown before. Sorry. Epilepsy, I already told you, is a very good indication. Why that? We looked prospectively at patients who were treated and those who were not treated surgically. And I can tell you, the patients share after 5 years have absolutely the same morbidity by the disease. The difference is those who were operated wouldn't have had any more hemorrhages and wouldn't have epilepsy any longer and wouldn't take drugs. And for that reason, this shows that epilepsy is a very good indication for surgery. The outcome is very good after that. And if it is possible, talking about the epilepsy, about cavernomas in non-eloquent regions like this one, you should remove the hemosiderine rim like here. Here, a very short video of this superficial, very easy case. This is a video that is several years old. You first remove the cavernoma, and then later you remove all these hemosiderine rim-like tissue when you are treating epilepsy. Then you would have the best outcome. Another very good indication is deep localization, because these lesions bear the high risk for rebleeding. And I just show you now some of the cases. You see here mesencephalic cavernoma reaching the surface at the dorsal rim of the mesencephalon and pons. I operate these lesions usually in sitting position, and it's really honestly quite easy to remove them using the gravity. The cerebellum slacks down, and it's easy to remove such a case like shown here. And typically the patients are immediately better after surgery. In this case, the hemiparesis resolved within days. Another case of a pontine lesion. Here, please note that it comes close to the surface on the lateral, and therefore a subtemporal transtentorial lateral approach is used. And same is true here. Hemiparesis is better very early on. However, when we're treating particularly brainstem lesions, you can see the numbers of this meta-analysis here. Long-term harm in 15% and mortality even in 1.5%. When I look to my own series, these are the numbers of 2020. I must say that my numbers are a bit better. However, we must admit that, of course, there's even a morbidity after surgery of deep-seated lesions. And we looked in our brainstem cases, and we asked the patients, how many of you would do surgery again? And it's interesting to note that far more than 90% would opt for surgery, to do surgery again. However, we must be aware the average time to return for work is approximately 9 months. And there's one more thing that I want to make a point of, and this is this image that you can see here. I don't know if anybody of you is aware of what this is. Of course, this is not a cavernoma. This is a so-called hypertrophic olivary degeneration, and this one was created by myself when I operated on this cavernoma here that had bled twice. I operated it after the second symptomatic hemorrhage, and the patient went home fine, very fine, but he returned several months later with an extremely severe dentorubral tremor, which is extremely disabling, and an ocular myoclonus that is absolutely problematic. And why that? Why happens that? We know that this is due to a problem that we give in between the connection of the dentate and the red nucleus. And therefore, the so-called Guillain-Muir triangle is altered. The connection is partially destroyed. And this gives this hypertrophic Oliver degeneration that typically arises only months after the treatment, and which is severely disabling. We collected a number of cases, altogether 20 cases, and my friend Marco Censato from Milano published that also in Journal of Neurosurgery in 2020. These individuals are severely disabled, and that we must be very aware we can cause this problem. Talking about deep-seated brainstem cavernomas, I think it's very important to look at the outcome of them in detail. And we did that and have also published that. So those of you who are interested in that, have a look at this, at these publications. Because if you opt to do such things, to remove brainstem cavernomas, you should be aware of that. And since it's very difficult to provide treatment recommendations, we performed the Delphi consensus. And also, thank you again, Giuseppe, you took part, but also a number of other quite famous international colleagues. We performed the Delphi consensus when we would recommend to do what. If you're not absolutely sure what to do in an individual patient, have a look at this publication. I always like to show this image. This is a 7 Tesla of a quite rare incidence. This is a hemicavernomatosis of the brain. I saw 2 cases like that in my career only. And I like to show that because I make a point out of that. If you see a patient like that, it becomes quite obvious. But be aware, if you treat a patient with multiple cavernomas, you can never heal that patient by removing one of them. And for that reason, you should be very defensive in surgical treatment of patients suffering from multiple cavernomas. Now, talking about treatment of cavernomas, I think it's always necessary to show something like the worst case. This is my worst case that I treated many years ago. Patient suffering from hemiparesis, which was coming and going several times. He had maybe 6 or 7 hemorrhages in that cavernoma. And finally, I decided to remove it through a Transsylvian approach. This was a very beautiful surgery. However, when I had removed the cavernoma in the end, I had a bleeding, very small intraparenchymal artery, and I tried to coagulate it for maybe 40 minutes, but it was not possible. So I had to leave a shunt clip. And in the end, the patient developed infarction that gave a nearly complete hemiplegia to the patient that remained. So that shows very much that it's very severely that we can cause, and that we always should be aware what we do, and that we should always do a risk stratification. We must stratificate the cost for the patient and the benefit for the patient. So I want to draw a first conclusion before I show you, if you're interested, 3 or 4 more interesting cases, also talking about surgical technique. But according to my belief, we should not treat incidental cavernomas. We wouldn't even follow up them. The treatment indications, as I've shown you, should always be guided by a strict risk stratification. And be aware, the surgical risk is determined by the localization of the lesion and also by the approach. The risk of hemorrhage has been mentioned now. What gives risk has been mentioned a lot, but particular deep localization and previous hemorrhage. Epilepsy is a very strong indication for treatment. Deep localization, very strong indication. There's a restricted indication for multiple lesions, and once again, always counterbalance the risk versus the conservative management. Now, let me show, Giuseppe, it's okay when I show?
Yes, please go ahead to show us some cases, especially if you have videos, and you know, we're interested how you think about the surgery and even some basic aspects of the microsurgical techniques. Absolutely.
So this is a case that I wouldn't treat nowadays. I treated that maybe 15 years ago. You can see this is a case from a family, and the patient had an MRI and a growing cavernoma here, and she was afraid to have a blockage of the foramen of Monroe, and we had a lot of discussion. And look, you can see a cavernoma here, and you see also one here. And in the end, you know, after long discussion, I removed it, and I just wanted to show you this is left-sided. So I did a interhemispheric transcallosal approach from the non-dominant right side. You can see it maybe here again. Interhemispheric, you see already I do the navigation, and I open it from the right side arrow in the contralateral ventricle by callosotomy, and then it's quite easy to remove the case. And then, of course, I check the arteries in the end, and the patient did very fine. But she came for a follow-up MRI 3 months later, and this is a 3 months later follow-up. This looks nice. This was an immediate post-op, and but look at the 3 months later, and she drove crazy because she had this one is removed, and she had a hemorrhage in between in the other one. And she drove completely crazy. So, and this is now left side, and she kind of forced me to also remove the asymptomatic. This was asymptomatic. This was done on follow-up, and I did it, and I removed it, and it went quite okay, as you can see here. But this, from my experience nowadays, I wouldn't have treated this one, and I wouldn't have treated that one. That is why I like to show the example. Here's another one, 19-year-old case, I think 4, 5, 6 years old. And she had 4 hemorrhages in 1 week, and she was hemiplegic and aphasic. Now, look at these images, and we are talking about approaches. What would be an approach to remove this image? Would you go through the insula, or would you come from temporals, subtemporal, or would you come trans-sylvian, or would you consider to do supracerebellar transthalamic approach? Well, I consider to do the same thing that I showed you before. I did the contralateral interhemispheric transcallosal transventricular transthalamic, and this is immediate post-op, and the patient did extremely well. So the aphasia was immediately resolved, and the hemiplegia resolved completely within 3 weeks after the surgery. Now, let's look at this one. Another basal ganglia one. I think I treated last year, and I was considering a trans-sylvian approach. Very important, particularly for deep-seated instruments. These are my special instruments that I use, even quite long ones. We did a typical frontotemporal craniotomy. This is double size. I'm not so hectic in surgery as it looks here. And maybe I can go a bit ahead. I open the Sylvian fissure. And if I would show you now the entire video, you would recognize that I now see M1, M2, M3. And my first plan was to enter above the M1. But above the M1 and above the M2, there were small upcoming, here you see one of them, some very small upcoming cortical suppliers, and therefore, I came from more lateral, and go to see when I'm now in the cavernoma, and this is a very high magnification. And what I like to show here is I use only coagulation for the lesion itself to shrink it and to make it a little bit more hardened, and then I pull the lesion in the cavity that was created by the lesion itself. Yeah, and when I see a very small vessel like here, then I cut it. Okay, but usually I wouldn't do any more. We can see a small venous lesion, a venous vein here. Yeah, I coagulate and then cut it, and by pulling that, we can then later can come down. Okay, this was already a third ventricular case. That's sorry, I skipped the previous one. This was a third ventricular case that I did also through a transcallosal approach here, and then stitching the falx, opening the ventricle, and doing opening the third ventricle here, and then you saw before what I did. I shrinked it, I pulled on it, and I pulled it in the cavity. Yeah, and in the end, the lesion is then gone. I'll show that. I think here you can see the I think you can acknowledge it. This was pre, and this is, I think this is post, when the lesion is completely removed, and the patient was fortunately doing fine, although there are a lot of risk of cough, of course, due to the localization. What I usually wouldn't do, so this is a quite old case again, I wouldn't do, if I can avoid that, I wouldn't do telovelo or transventricular force ventricular approach, because like in this lesion, because as you can see here, the stria medullaris are below. Usually what happens if you remove like this, you will give the patient some harm, either it's the 7th or the 6th or even both nerves. So in more recent cases, I wouldn't do such an approach. This is a post of this region. I would usually do another approach recently, and this is what is called in American literature the far lateral. This is a publication of Michael, and he does it in park bench position. I do it in a sitting position. So this is the same images, his view, my view, and you see this case here, for example, a lesion that is quite ugly because it's reaching the ventral surface of the pons. And come on, I don't know the view. This is a positioning of the patient. Skin incision, craniotomy, opening, dural opening, and now opening. You see the caudal nerves, and you can see here where it reaches the surface, and you see my super nice bipolar. I don't know why the video doesn't run. I have to run it my like this, and here you will see the same thing. I always push it and pull it in the cavity, and then advance it as low as less as few as possible bipolar, and then in the end it comes out completely. And here is another case. I think this is the last case that I would like to show. So this was in, I don't know why it doesn't run. This one runs. 2016, look at that. And that what is happening. In 2019, it had several hemorrhages and reaches the surface now lateral below. So same approach, far lateral approach, drilling a bit of the condyle, and then opening the dura, releasing the CSF. And now we can, below the cranial nerves, you can see the lesion on the surface. Then you use the colorized surface, again my bipole. And I'm going to advance it a bit. So the same thing. Sorry, the same thing that you can see here. I push it and pull it until in the end I can remove it. Somehow the video doesn't work properly. I'm very sorry for that. Maybe even a rest, and also like to leave some surgical cell in the end, and the patient is then should be then fine after surgery. Yeah, that's it. I thank you very much for your interest in our work and in cavernomas. And I'm, of course, open for any questions. And once again, I have to apologize for the video. There's some problem with my software. It looks like that. Thank you, all of you.
Thank you, Professor Zero. It's a great talk about, comprehensive talk about the surgical aspect of the cavernoma. So before moving to the general discussion, let me give a couple of questions before that. So the first question is, you indicated the decreased QOL in the asymptomatic cavernoma. So what is the mechanism of the QOL decline in patients with asymptomatic?
What is the can you please?
Mechanism, yeah. How? Why? What is the reason that the asymptomatic cavernoma patient has a decreased QOL? Because the patient asymptomatic.
Yeah. The QOL, quality of life.
Yeah.
The reason is that usually the patient, let's say, would have a headache, and a colleague would then perform an MRI. And then the patient is found with a vascular lesion. Mm-hmm. And then the radiologist tells the patient, oh, you have a vascular lesion. This is prone to hemorrhage, or even maybe has had a small hemorrhage already. And that gives a lot of stress to the patient, because the patient maybe would have fears that he or she would have a hemorrhage that gives severe disability to them.
Thank you. I understand. My last question is, it's interesting, you don't recommend the MRI follow-up for the asymptomatic case. I understand. So my question is, how often do you follow up for the post-operative cases? Every 6 months, or maybe it depends on the surgery?
No. When the post-operative cases, we follow up after 6 months once.
Okay.
And if the cavernoma is removed completely after 6 months, by the way, it doesn't make sense to do it 3 or 6 weeks after that, because we can't be sure with the MRI after 3 or 6 weeks. But after 6 months, if the cavernoma is removed, that's it. No more follow-up.
No more follow-up. Okay, okay. That's your problem. Okay, so Professor Lanzino, you can move to the general discussion.
Yeah, we can move to the. I was monitoring the chat. I don't think there are questions. I'll like to make a couple of comments on the surgical approach, particularly to brainstem lesions. And this is, of course, the webinar is steered toward our younger colleagues. What I've learned is that quite often when you go there, especially if it's the cavernous malformation, there is not a hemorrhagic component. You get the impression that the cavernous malformation is really stuck to the surrounding brain. And but what I learned, as you do the piecemeal resection, and then you start going, you start pulling the cavernous malformation. If you are patient, the brain itself, the brainstem will as it will start compressing the remaining cavernous malformation toward your opening, because when they bleed, the cavernous malformations distend rather than destroying the surrounding brain. So I learned that it's important to be extremely patient and careful, especially in the initial parts where you get the impression that the cavernous malformation is terribly stuck to the surrounding brain. And the other thing that I'm always amazed is that as you go, you see often a small portion of the cavernous malformation comes to the surface, and you enter there, or you do a small incision through so-called safe entry zones. I'm always amazed as you proceed in the resection, your opening actually naturally enlarges. And the other point that I like to make, I cannot stress enough the importance that Professor Sure mentioned, how to be careful about the fourth ventricle, because truly when I look at my morbidity after surgery for brainstem cavernous malformations, doesn't seem to be related to long tracts. It's not hemiplegia or hemiparesis. It's not so much specific cranial nerves, but it's mostly the associated fibers, the medial longitudinal fasciculus. Patients develop funny high symptoms and constant sense of disorientation in space. And the other thing is that, remember, the cavernous malformation displaces rather than destroying surrounding brain. So you will be amazed at how much normal parenchyma is there, even though when on the MRI you get the impression that the cavernous malformation, it's very close to the surface. After you remove the cavernous malformations, again, you realize that there was much more parenchyma than you thought, and that's because, of course, the parenchyma was extremely compressed. We can proceed with Professor Fujimura cases now. Looking forward to those.
Oh, I don't have a specific case today, but yeah. I have one question about the hypertrophic olivary degeneration. I learned a lot from your lecture, and my question is, what is the exact incidence of this deleterious complication because you have a huge series, so you know the incident. Yeah. Is it very rare or sometimes happens? Or?
Yes, I can say when we checked our cases, we had I think 120 cases. We had two severe. I showed you the most severe case before by imaging. We had two severe cases, but we had two other cases who were also quite, maybe not absolutely severely, but disabled, who had a very similar thing. So And when you speak to Robert Spetzler, he has seen also the same thing. I think he has contributed 4 or 5 cases, but in case of the Spetzler series, it's a bit difficult because he treats a lot of international patients, so follow-up might not be absolutely complete after years. In my series or in our series, I would say we would have a quite complete follow-up. So it should be something between 1 and 2%. And also interesting is, as you have seen, the lesion that I have shown you was a quite straightforward lesion, wasn't it? It was on the dorsal surface of midbrain, connection to the pons. Yeah, but this is very close to the upper cerebellar peduncle, and I think, or I know, of course, that the Guillain-Moiré triangle, the connections, the fibers, they are running here. We must be very aware of that. And I think what is so absolutely bad is, you know, the patient is feeling very good after surgery, better than before. The surgeon is feeling good because he helped the patient, and then a couple of months later, you meet such a patient who comes in a wheelchair, which is very bad.
Okay,
1-2%, I would think.
1 to 2%. Okay, thank you.
Very good. If we don't have any more questions, I'd like to thank the participants, my co-moderator, and Professor Sure for another great presentation on the topic, and for sharing his incredible experience with this disease. And I also invite everybody to join us for the next webinar. It will be on November 23rd, and the topic will be global neurosurgery, especially as it applies to cerebrovascular surgery, challenges and opportunities. Thank you, everybody.